Hello everyone and welcome to today's webinar, Women with Hysterectomy, Premature or Early Menopause, Predictors and Health Consequences. My name is Sarah and I'll be your moderator for today's event. Before we get started, I want to go over a few housekeeping items so you know how to participate. You have entered this webinar in listen-only mode. That simply means that you are muted so we don't pick up any noise from your end. We do welcome and encourage you to submit your text questions via the questions pane in your GoToWebinar control panel. You can enter your questions at any time and we will save them for Q&A at the end of the presentation. If you have any technical difficulties, please type them into that same questions pane and I will work with you directly to resolve those ASAP. We are recording today's webinar and you'll receive a follow-up email that will include the recording. By submitting your questions today, you agree to have them read aloud and recorded. At the close of today's session, you will get a brief survey to fill out and we appreciate your response. All right, thank you for joining us today. I would now like to introduce your presenter, Gita Mishra. Welcome, Gita. You now have the floor.
Thank you, Sarah. Can everybody see me and hear me all right?
You look good. I think we're good to go.
Okay, all right. So first of all, good afternoon, everyone. I'd like to thank Tommaso and Irene for really giving me the opportunity to present today, and in particular as the board member for EMAS. As an epidemiologist, my take on this topic is really in utilizing large data sets to help inform the trend and also the risk factors associated with hysterectomy, premature or early menopause. Before I go on, I also like to thank two people in particular, and one is my PhD student, Louise Wilson, who's working on this topic and has kindly provided me with her slides, and also Shin Fan, who has done a lot of the work from Interlace, which you will see. So what I'm going to do today is really to talk about hysterectomy. I think that it is a procedure that is quite common and yet it's being understudied. So we'll look at the prevalence, the risk factors, and this is both from the meta-analysis that we've recently conducted, but also results from this large pool consortium, Interlace. We will also look at the vasomotor menopausal symptoms, the patterns in women with and without hysterectomy, and the two new topics that you are going to see is we're going to discuss how hysterectomy is associated with the development or the new cases of depression and diabetes. After we've done hysterectomy, we will then move on and talk about premature and early menopause, and I'll share with you some of the results, the prevalence, and also risk factors, and hope to conclude the seminar with some implications. I think that whenever we're studying women's health and NCDs, it is important to take a life course approach. And in fact, what you'll see here today is that I'm going to focus on aspects of reproductive aging, which is hysterectomy and oophorectomy, and also premature and early menopause. But we know that these are associated with chronic conditions later in life. But also, what are the predictors? And when we try and take a life course approach, in other words, we try and look at factors earlier in life that could be a risk factor for our for reproductive aging. So as a definition, I think menopause, when we think about menopause, the age of menopause, it is a biological marker of health, and also it's a marker of the ovarian or reproductive aging. And in fact, age of menopause can be thought about as our biological age. It is marked by marks the end of a woman's reproductive stage of life. And usually, as I was saying before, a lot of work has been done looking at natural menopause. And so natural menopause is an age-related process that involves the failure of the ovarian functions. And usually it happens from a woman going through from premenopause to peri, then to postmenopause. So there's these processes involved. And there is a slow decline in the ovarian hormones. Then comes surgical menopause. Now, strictly speaking, surgical menopause is the removal of both ovaries, and it's known as bilateral oophorectomy. When a woman goes through surgical menopause, she experiences an abrupt disruption in the ovarian steroids, so from estrogen, progesterone, and also testosterone. And usually surgical menopause is performed during the time of hysterectomy. The other third thing that can affect the timing of menopause is actually hysterectomy. So hysterectomy is the surgical removal of the uterus, and hysterectomy with ovarian conservation means that the ovaries are intact but the uterus have been removed. Now in this case, there is a twofold increase in the risk of ovarian failure, and in fact more than 20% of the women will experience symptoms of diminished ovarian reserve within a year. So even though she has the ovary, it still affects the ovarian reserve. So I think that when studying reproductive aging, these are some of the stages or factors that people do need to take into account. So why is that important? And because there are adverse health consequences that has been shown to be associated with hysterectomy and also with premature and early menopause. These are some of the symptoms. For instance, women are more likely to experience severe menopausal symptoms, and also there's an increased risk of type 2 diabetes, osteoporosis, heart disease, and premature death. And you can see those references. But there is a lot of work that still needs to be done in terms of trying to understand how hysterectomy is associated with the development of new cases of diabetes or depression, and that's something that I will be touching on later on. So a bit about hysterectomy. Usually it's performed, so this is the removal of the uterus. It's usually performed in about 80 to 90% for benign indications. So for instance, uterine fibroids, dysfunctional uterine bleeding, endometriosis, and prolapse. The incidence of hysterectomy, so this piece of work was actually taken from the work of Hammer et al. It was published in the American Journal of Obs and Gynecology in 2015. But what you'll notice is most of the data that they've used is not that recent. For instance, the Australian data is more than 10 years old, and so is the Germany data from Germany. But what you get an indication of here is, for instance, in the US, this is more than almost 20 years ago, there was 51 per 10,000. That was the incidence rate of hysterectomy. So it's high, quite high in the US, and then UK and Australia follows quite similar to about 35 people per 10,000 women. I can show you a more recent work that we were done, and in Australia in particular, we find that approximately 20% of the hysterectomies performed in Australia also includes the removal of both ovaries. Between 2000 and 2014, here alone we have about 31,000 hysterectomies were performed annually, and that's a large figure. From this graph here, what you'll see is that there has been a decline in the incidence of hysterectomies that was performed between 2000 and 2009. So from 65 women per 10,000 to 46 women per 10,000, and then it has stayed plateaued to about 47 women per 10,000. This is age standardized rate. It's still very high. And in fact, so this is using Australian population-based data. And in fact, in 2013 and 14, the highest percentage of hysterectomies was in women between the age of 45 to 54 years in that age group. So we performed a systematic review trying to look and see what's been published in terms of the risk factors for hysterectomy. And what you'll see is that one of the things that came out consistently is the level of education. So women so the hazards ratio was about 1.87 or 1.9, comparing the lowest women with lowest level of education compared with the highest level. So that was the odds hazards ratio, and the similar sort of information you get whether you use odds ratios or hazards ratio, that it's higher in, the risk is higher or the likelihood is higher in women with the lowest level of education. The other thing we also found out was age of menarche. Now, age of menarche has been shown to be associated with an increased, a lower age of menarche has been shown to be associated with an increased odds of having hysterectomy. And both using hazards ratio or odds ratio showed the same pattern, but I want to draw your attention to the number of studies that's been done. That's 2 studies, that's meta-analysis of 2 studies, and this is of 5 studies that have shown. What is a little bit surprising though is in relation to parity and the risk of hysterectomy. From the published work, we did not find a relationship between number of children with the risk of hysterectomy. At least this is just pulling all the published work, and you can see there are 4 studies that have contributed to this meta-analysis. So from this slide, it is quite clear that the level of education and age of menarche has been associated with hysterectomy. The finding wasn't significant for parity. The other factors across the life course that we saw was we looked at was occupation, the occupation of the woman or her spouse. There was no relationship with occupation of the spouse. With the women's own occupation, there is a possibility of an increased risk in women with lower occupational levels, and this ties in quite nicely with the result we see for education levels. You'll find that there's inconsistent results with children, the socioeconomic status during childhood. There was also not a lot of evidence in terms of the age at first birth from this systematic review, but there's an indication that possibly the risk is higher in younger age at first birth. And similarly, we looked at miscarriages, the number of cesarean here. Again, it shows that there's a possible increased risk. But again, only 1 study contributed to that. With respect to BMI, it's shown that it's a possible increase with women with higher BMI. Both for smoking and physical activity, the results were inconsistent, at least using all the published work to date. So what we were able to do was to actually look at the relationship in terms of these social demographic characteristics and whether we see the same thing when we pull the data from Interlace. So Interlace is an international collaboration for a life course approach to women's reproductive health and chronic disease events, and it's been funded by the Australian National Health and Medical Research Council and also by the Australian Research Council. You can read more about Interlace in our article that was published in Maturitas last year, and there we described the study. But I'm pleased to say that to date there were 3 other studies have joined Interlace. That brings the total number of women in this consortium now to over 500,000 women. And the women are from 10 different countries and from 23 studies. And one of the things that we were able to do was to start looking at whether there is any geographical variation in the prevalence of hysterectomy. And that's important because it points out to something about the health systems in a particular country. So, for instance, if you look at this graph, what you find is in Japan, the percentage of prevalence of hysterectomy is very low. It is less than 4%. Whereas if you look at countries such as Australia, for instance, that is 30% of our women have had hysterectomy. And that's quite high. In the UK, it's about 1 in 5 women. And in France, it's about 1 in 6 women that would have had hysterectomy. Now we want to, the next thing we did was we wanted to see whether there was any difference in terms of regional difference in based on race and ethnicity. And what you can see here is again, that I want to draw your attention to. If you look at the Caucasian living in the US, that rate of hysterectomy is about 10%, whereas if you look at the African American blacks living in the US, that percent is almost double to 20%. Women, the Caucasian women living in Europe, their rate of hysterectomy is around 18%. And in Australia it's about 31%. So it does show that there are differences in terms of race, but also regions of residence. And places like in Australia, I can probably say that it is our health system that is in some ways encouraging the higher rates of hysterectomy. So using Interlace data, what do we see? Do we see still the same sort of effects? And I'm pleased to say that using data from around 500,000 women, we find that those who've had no formal qualification or those who have year 10 or equivalent qualification are at a higher risk of or have a higher prevalence of hysterectomy compared with college or university educated women. So this supports the results we saw in the meta-analysis previously. We could provide a more conclusive evidence in terms of the relationship between hysterectomy and body mass index. Here we do see that women, there's a, I won't say nice, but there is a nice linear trend in terms of a sort of a dose response. So the heavier the women are, the higher is the percentage of having hysterectomy. So you can see it goes from 7% to 24%. So we found conclusive evidence of the overweight and obesity with hysterectomy. The similar sort of relationship we found very, very strongly was that women who've had menarche under the age of 10 or by age of 11, they are at a higher risk of having a hysterectomy compared with women who've had their menarche at the normal age of around 12 or 13 years. So again, this is something that is also been shown in the meta-analysis from published work previously, but now we're able to confirm these results using a much larger and individual level data. In terms of number of children, which we were really surprised that the published work provided an inconclusive evidence, but what we can see is using again this, 500,000 data from 500,000 women, we can actually see that there is a dose-response relationship between parity and hysterectomy. In other words, the more children the women had, the higher is the prevalence of hysterectomy in that group. So women who've had 5 or more children, that prevalence goes to 1 in 4 women would have had hysterectomy. The other things, again, factors that affect hysterectomy is you'll find that those who, younger mothers, so those who've given birth by the age of under the age of 20, about 30% of them would have had hysterectomy later on. So age at first birth is also saying something. So in terms of studying prevalence of hysterectomy, it is a very common gynecological procedure, and definitely very common in Australia, and also it looks like in Europe, where you have about 18% of your women having a hysterectomy. So we found that women who lived in Australia from this study, who have lower levels of education, higher BMI, those who've had earlier menarche, more children, and have a first child at a younger age, these are all associated with a higher risk of having hysterectomy. So the thing is that because it is quite common, how does it affect the women's quality of life and her chronic disease profile? So this work was work of my PhD student Louise, and was published in Maturitas last year. And probably this is one of the first study to actually look at the patterns of hot flushes and night sweats over a 17 years period to see whether women who've had hysterectomy, their pattern is different to women who don't. So that was the aim of the study, is to study to determine the symptoms patterns for hot flushes and night sweats by hysterectomy status, and also to test whether the differences in the symptoms pattern differ between women with and without a hysterectomy. So the study population comes from the Australian long-term study on women's health. It's a mid-cohort women. The study started in 1996 when there were about 13,000 women, and they've been followed ever since. This particular study has been funded by the Australian Government Department of Health. The data that I'm going to show you was the ones that have been collected over 7 surveys. So when the women were aged 45 to 50, right till when they were aged 62 to 67, same group of women that we followed. The hysterectomy status are women who've had hysterectomy at baseline, so they were between the ages of 45 to 50, so at baseline they've already had a hysterectomy, and they did not have both ovaries removed at baseline or subsequent survey. So these are just your pure hysterectomy group at baseline. The control group was women who've never had a hysterectomy or whose both ovaries were removed over the 7 survey. So they were your women with both uterus and ovaries. That was your control group. The symptoms, for the vasomotor symptoms, we looked at the frequency of hot flushes and night sweats in the last 12 months over the 7 surveys. So we used longitudinal methods to do that, to look at the patterns, and we adjusted for the usual covariates. So when we looked at the descriptive, we found that women with hysterectomy, it's not surprise, confirmed, again, what we saw with the studies from Interlace. Women were more likely to be obese across all surveys. They were current smokers. They were also never or rarely drinkers. They had lower levels of education, and they were older at baseline. So they were more likely to be in the 49 to 50 years old compared with being in the 45 to 46 years old. And also these women who with a hysterectomy were more likely to be hormone therapy users. And we're comparing it with women who've never had a hysterectomy. Now, this is something that the study has contributed to, and this is the pattern of hot flushes. So what we found was that when we look at the patterns of hot flushes across the 17 survey, we found that there's 4 typical patterns of sometimes or often hot flushes across that 17 years. So we had the red one showing constant patterns. So these women had reported sometimes or often constantly over that 17 years period. We also label women with minimal as minimal, and these are minimal symptoms that they experience. And then you can see the dark green, that refers to women who've had early onset. So they've had symptoms before by the age of 55 really. And then, so these are the early onset group. And then the yellow one are the late onset group. That means they had symptoms a lot later, in their late 50s. So when you compare women with hysterectomy and never hysterectomy, you find that those who've had hysterectomy at baseline, they were more likely to report almost double, report constant. 32% of them reported constant, experiencing the symptoms constantly, compared with 17% of those who had never had hysterectomy. And similarly, they're more likely to have experienced an early onset of hysterectomy. So it's early, and also it's prolonged or enduring experience of that symptom. And we see exactly the same sort of thing with night sweats. Again, they're more likely to, 29% of them experience early onset of symptoms as opposed to those who are never in the never hysterectomy group. And certainly almost double experience constant symptoms. So that is 1 in 5. Across 17 years, they were still experiencing the symptoms. So that's just to show you that if you were to compare women with the mild symptom as your reference group, you find that women with hot flushes, they're less likely to be in the late onset group. They're more likely to be in the early onset group or in the constant, and that is clinically meaningful magnitude we're looking at, and odds ratios of 2, that is double. Similarly, if you see the pattern for night sweats, again, they're more likely to be in the early onset group and also constant. So what this results does using longitudinal data is that it shows that helps us to understand, and it will help in the management of the menopausal symptoms, especially if you know that they've had their hysterectomy by the age of 50, they are at a higher risk of experiencing menopausal symptoms, and also for a long period of time. The other thing we've done is to look at the incidence of depressive symptoms in middle-aged women, and the beauty of this is, again, we've got the women who've had hysterectomy by baseline, so by the age of 50, and there's about over 2,000 of women have already had that hysterectomy, 2,000 out of about 13,000 women. And so we wanted to look at the relationship and quantify the relationship with incidence of depression, because depressive disorder does impose quite a high non-fatal burden on the woman. In fact, in Australia, it's the fifth non-fatal burden. So there is a long history of hysterectomies being linked with psychiatric disorders, but there's been limited longitudinal research, and so we don't know whether they were depressed and then they had hysterectomy, or whether they had hysterectomy and then that increased their risk of depression. So the aim here was to investigate the association between hysterectomy status and the incidence of depressive symptoms over a 12-year period. So it's the same study and it's the same group of women, and here basically they've had hysterectomy as survey 1. By survey 1 they've already had hysterectomy, and then they were free of any depressive symptoms, and then we wanted to see what happens to them between survey 3 to 7, whether they develop depression then. So the group is identical to the ones that we've done before, but here we have another group of women. So the hysterectomy status was divided by 3 groups. The first one is women who've had hysterectomy at baseline, and they did not have their both ovaries removed. So they just had hysterectomy. So it's a hysterectomy only group. Then the second group is women who've had hysterectomy and both ovaries removed. So if you recall, this is your surgical menopause group. And then the third one is the control is women who've never had hysterectomy. And the measure of depressive symptoms was the 10-item CESD scale from survey 3 to survey 7. And we adjusted for the covariates. Very quickly, what you find is CSD score of greater than 10 can be considered as a case. So they can be considered as having the symptoms of depression. So here you'll see that hysterectomy only group, again, slightly higher, 18% of them have a CSD score of greater than 10, compared with 15% with CSD score less than 10. But really those who've had both ovaries removed, that number is almost doubled, and so forth. So if you look at just the prevalence of depressive symptoms here over time, so the different colored bar you see refers to the different ages. So this is when they were 50 to 55, here when they were 62 to 67 years old. And really what I wanted to point out here is that this is a group depression, percentage of depression amongst women with no hysterectomy over time. So what you'll notice is that the prevalence of depression do go down over time in all the 3 groups, but they're starting out at a different level. So here the average would be around, in this group would be around 14%. Here maybe the average is around 17% of the women, and then here you see it's over 20%. So women with hysterectomy, bilateral oophorectomy are at a higher risk of depressive symptoms, or they report it more. And that's just to show you the hysterectomy only group, that is the relative risk of depressive symptoms, and the women with hysterectomy and bilateral oophorectomy have a much higher risk of depressive symptoms. And when you adjust for all the other factors, it does bring it down a little bit, but nonetheless it is still significant. So the risk is still quite high in both groups, and in particular the women who've experienced surgical menopause. So the conclusion from here is that the 5 years post-surgery, women with a hysterectomy were at a higher risk of new, that's the key thing here, the new incidence of depressive symptoms than women without a hysterectomy. So what we wanted to know was whether the effect of hysterectomy was um, um, looking at the relationship between hysterectomy and diabetes, and what is the role of body mass index. So that was the other second chronic conditions that we looked at, was diabetes. Is the world fastest growing chronic conditions, and we find that about 12% of the global expenditure is on management of diabetes. There's a rationale why we think that hysterectomy may be associated with diabetes. So for instance, the role of ovarian hormones in regulation of glucose uptake and insulin sensitivity. So hysterectomy is associated with changes in blood supplies to the ovaries and hormone levels. And if you remember, I mentioned earlier that that was associated with a decline in ovarian function, hysterectomy. We also know that overweight and obese are key risk factors for diabetes, and we also know that women with hysterectomy are also more likely to be overweight and obese. So this is an example of a directed acyclical graph, and we wanted to know what happened if we change the body mass index, or can we change the negative effect of hysterectomy on diabetes. So we wanted to quantify the mediating effect of body mass index on the association between hysterectomy and incidence of diabetes. Okay, so what we saw was that hysterectomy is associated, there's a direct effect of hysterectomy on diabetes that doesn't go through body mass index. So again, women with hysterectomy have got the odds of 1.7 times of getting diabetes. And it partly goes through body mass index. And I'll tell you how many percent of the effect of hysterectomy goes through diabetes. But the bottom line here shows that if you take into account the total effect of hysterectomy on diabetes, that's almost 2 times. So women who've had hysterectomy have twice the odds of developing diabetes compared with women who didn't have hysterectomy. Now, the effect of hysterectomy, because we know that obesity is associated with diabetes, only 23 or 23% of the effect of hysterectomy on diabetes goes through body mass index. So if you were to encourage the women to lose weight, you can mitigate the effect, the negative effect of hysterectomy on diabetes by about 23%. So it's still something definitely worth in terms of intervention. So that's my lecture on premature and early menopause and on hysterectomy. I'll just very quickly go through premature and early menopause. So these, again, the very similar work looking at conceptual framework. And I think it's important that we be able to, when we talk about age of menopause, really some of our earlier work has shown that age of menopause is actually, it's not a symmetrical distribution. It has a very long left-hand side tail. It's a mixture of two distributions. One is very early menopause and one is late menopause. And if you put these two distributions together, you can describe age of menopause. So there's a lot of early life factors that is associated with age of menopause that we've worked on. But really now with the ability of having pooled data from the Interlace Consortium, it gives us the power to be able to look at early and premature menopause in much greater detail because we have the numbers and the power to be able to do that. So using interlace, this work was published earlier this year. What we find is around 2% of our women have had early menopause. Premature menopause. So premature menopause is experiencing menopause by the age of 40. Another name for premature menopause is the primary ovarian failure. And early menopause is reaching menopause under the age of 45, and that's about 8%. So you can see that premature and early menopause, that's about 10% of the women will experience it, and we know that that's going to put them at an increased risk of chronic conditions later in life. So what are the factors, what are the drivers of early premature and early menopause? And we can see here that the levels of education, so women who've had less than 10 years of schooling, and this is from the Interlace Consortium, or even schooling under the or 11 to 12 years of schooling, you can see that their risk of experiencing premature menopause under the age of 40 is around 2, 1.9, that's 2, 1.8. Similarly, they had an increased risk of experiencing early menopause. There's some evidence that marital status was associated with earlier menopause. So here the reference group is women who've had menopause between the ages of 50 to 51. We're comparing, that's our reference group. And this results from multinomial regression. What about current smokers? It's not surprising that women who are current smokers have got higher risk of premature and early menopause. And what we're finding that is quite strong from this large data set is actually women who are underweight are at a much higher risk of experiencing premature menopause. The relationship with menopause is really in some sense a U-shape, because both underweight women and obese women seems to be at a higher risk of experiencing premature menopause compared with those who experience menopause at the normal age of 50 to 51. The other thing that we were quite surprised is again the story, early life factors, and here again the age of menopause. Menarche. We found that women who had the menarche before the age of, or by the age of 11, they had a relative risk of 1.8 times of experiencing premature menopause. This is really, before the age of 40, compared with experiencing menopause at the age of 50 to 51. That's a reference category. And we were also quite surprised that at least in the Interlace Consortium, we found that women who've had no children, they had more than two times the risk of getting premature menopause. Similarly, women with one child had a higher 1.5 times the risk of having premature menopause. One of the reasons, given the so what we find quite strong here is menarche before the age of 11, and also premature, and having no children. And we wanted to see if there was, what happened if you combine, so looking at women who've had menarche before the age of 11 and also those who don't have any children, what is their relative risk? And there was an interaction between these two variables. And what we found is that women who have had early menarche with no children, their relative risk is 5 times, so 5-fold higher of having premature menopause compared with women who have their menopause at the age of 50 to 51, right? 50 to 51 with 2 children. That was their reference group. So here really what it tells us is that something that happens to us in early life seems to be determining the our ovarian aging. Right? So the combination, that two combination was pretty strongly associated with experiencing premature and early menopause. So here nulliparity and early age of menarche was associated with higher risk of premature and early menopause, and these are some of the lifestyle and socioeconomic status that we found. So in conclusion, really the summary is that post-surgery women with hysterectomy are at increased risk of developing depression and diabetes. They're also more likely to experience ongoing vasomotor symptoms. With respect to our results with early and premature menopause, we found what we're suggesting is early monitoring of women with early menarche, especially those with no children, for preventive health interventions that aim to mitigate the risk of adverse health outcomes associated with early menopause. So that we've given plenty of warning to be able to monitor these women. The study, so thank you very much for listening. These are acknowledgement for our colleagues in the Interlace Consortium. And again, I'd like to acknowledge my postdoctoral fellow, Shin-Fen Chung, and also Louise Wilson, PhD student, provided most of the slides. And for those of you who are listening, and just to again encourage all of you to attend the 12th European Congress on Menopause and Menopause. It'll be in Berlin, and I'm sure it'll be a very exciting event. I'm certainly looking forward to being there. And I think that's the end of the formal part of my presentation. And Sarah, are you going to put the poll questions up now?
Sure, thank you so much.
Thank you. Thanks.
We do have a few polls for you guys to answer here, so I'm going to go ahead and launch the first one and give you a few seconds. While you're responding to these, also if you have any questions that have come to you during the presentation today, you can type them into the question section of your GoToWebinar control panel, and I will relay those on your behalf. But go ahead and take a few minutes here, and we'll go ahead and vote in this first poll. I'll give you a few more seconds. All right, I'll share the results of this first one here if you want to speak to those. Gita, can you see them?
Yes, I can. So you've highlighted, yes. So what can affect the timing of menopause? Both that is hysterectomy, removal of the uterus, and also the removal of both ovaries. So the correct answer is C.
All right.
Yes, and majority got that.
We have another one here for you. What is the prevalence of hysterectomy among Caucasian Europeans? You can select one of the following. And again, while we're taking these polls, if you have any questions that have come to you, please type them into the questions section of your GoToWebinar control panel, and I'll be able to see those. A few more seconds here on this one. All right.
Oh, that's interesting. So yes, majority got it right. So Caucasian European, it's 18%. The figure for 30% is actually Australian Caucasian.
Okay.
Yeah. So majority got it right. 18% is the answer.
And one more for you here. give you a few seconds to answer this one. Okay, one more second here. Get those answers in. All right.
Yes. So it's the combination of women who've had menarche by 11 years and also those who have no children. Yeah, they're 5 times the rest. So majority got it right.
All right.
Yeah. The first answer that says menarche by the age of 11, that is only twofold increase, not 5. So it's not having children and having earlier menarche was associated with a 5-fold increase.
All right. Well, thank you everyone for those responses to the polls. We did get a few questions here and just want to invite people to keep typing their questions in. The first question, were any of the participants taking HRT?
For which question, which study are you, for interlace, we adjusted for HRT use. So depending on which question, which studies we're looking at. If they are taking it in terms of symptoms, we certainly adjusted for that result.
Okay. And then we had another question, maybe more about the presentation itself. It looks like somebody wants to see the figures that you were referring to. I don't know if you have any plans to send that out or if they have access to that information elsewhere. Something about the graphs that you were
Yeah,
referring to.
yeah. So which graphs are we?
If you can be
Some,
more specific,
yeah.
but I think it was just, I mean, it was a presentation referring to the figures, so maybe that's what he's talking about.
Because some of the presentations, some of them are all published. The interlace one, I actually pulled some of the analysis out really quickly for this presentation because I wanted to see what we were, whether we could replicate those findings. So certainly happy to, if people can email me their, slides or requests, I'm happy to send what I can to them or refer.
Okay. And we have another question that just came in. Did you include any cesarean hysterectomy study into your interlace study?
Cesarean, it's a good question. We actually, it wasn't one of the questions we ask for the variables that we ask our cohort, but I do know that on hand I have cesarean information from at least 5 cohorts. So I didn't ask consistently, but I know that in the database that we have, there are that information from at least 5 of them. So that's an interesting one to really look at some of the cesarean, that information associated with some of the health outcomes.
Okay. They said thank you so much. All right. Any other questions here? I'll give you guys just a minute. Feel free. Please type them into the questions pane of your GoToWebinar control panel. Gita, do you have anything else you'd like to share before we wrap up?
Not really. What I want to share with everybody, it's really, it is important, it's a hot topic, and there's a lot of things to come out from this large international consortium. So, very happy to take questions, suggestions, and people can email me if there's something that they think they've got some information on.
Okay.
Or they want me to check something. Happy to do that.
Okay, we did just get one more question here. I think we have a few more minutes. What is your view of the need to initiate HRT for patients who experience early menopause, and for how long?
Look, definitely, I think, I'll go with the guidelines. I think for symptoms for the shortest possible time. But it's interesting because from our study, when we look at the women who have consistent symptoms, women who've had hysterectomy by 50, they were experiencing symptoms. A small group of them, or 32% of them, were experiencing symptoms for 17 years. So exactly when do you stop? I can't answer that, but definitely if they've had four bad symptoms, then they should take it at least up to the recommended age of around the timing of natural menopause, so around 50 years, 51 years. Let's see. I also would like to encourage women to, look at other lifestyle factors as well, what they can modify through diet and exercise and
Oh,
losing weight. Mm.
we just got one more good question here I think we can squeeze in. And if anyone else has any other questions, please keep typing them in and we can pull them offline and respond individually. But
Yeah.
this one reads, what do you think is the reason for the significantly increased rates of hysterectomy in Australia than the UK?
Mhm. I can tell you that a few years ago, what we did was we compared women because we wanted to know what was so different or special. Why are Australian women having more hysterectomy? And so what we did was we did a comparative study where we had a group of women. So the 1946 British-born cohort. So they were British-born and they lived in Britain all their life. And then in Australia, in the Australian Long-Term Study of Women's Health, we have two groups of women. One who were born in Britain in 1946, but they migrated to Australia as a child, so they've lived in Australia all the time. And then we have another cohort of white Caucasian Australian-born women living in Australia. So we have three groups of women. And what we found is that the one who were born in Britain and stayed in Britain have that 20% chance of the prevalence of hysterectomy in that group was about 20%. But those who were born in Britain but lived in Australia, or those who lived in Australia in their entire life, their prevalence of hysterectomy was about 30%, right? So that clearly, in my mind, marks something about our health system. It's quite, in terms of, it is funded, is provide healthcare services free in Australia, and so I've got a feeling that, procedures like that, if the women experience prolapse or whatever, it's quite easily encouraged to have hysterectomy, at least in those. So I think it's our health system that's promoting it more than any other reason why Australians are different to women. But this simple kind of almost a natural experiment study clearly indicate there's something unique about in Australia then. Yeah. That's where I'm seeing.
All right, well, thank you so much, Gita, and that concludes the Q&A portion of today's webinar and the webinar itself. So thank you so much, Gita, for your wonderful presentation, and thank
Thank
you
you.
to all the attendees for being here today. Just a reminder, you will get a brief survey that'll pop up when I end the webinar, so please take a moment to fill that out, and we really appreciate it. So thanks again, everyone, and have a great rest of your day.
All right. Thank you. Bye. Bye-bye.
Bye-bye, everyone.